Ladies and gentlemen, I'm now going to give you an experience. I want RPA's comprehensive stroke team to move towards me rapidly. Meanwhile, a large number of patients who are all survivors of stroke are going to gather in a flash mob. And as you can see, they are holding cards, and we'll get them on screen quickly. I'd like to introduce you. I'm going quick because RPA launched in 24/7 statewide service offering endovascular clot retrieval, and speed is everything. Every year, 51,000 Australians have a stroke. It's every age, one person every 10 minutes. Beside me, come forward, is the woman I'm going to call Nurse. How do I pronounce your surname?
Tastula.
Kylie Tasula, Clinical Nurse Consultant, Neurosciences. Associate Professor John Worthington, Director of Stroke, RPA. You will now be Dr. John.
Good morning.
Good morning. Tell me, introduce us. We're going to do in the exact time they call it needle to groin, but we'll come back to that later. We're going to do, explain this service to you in the time they need to actually identify, get a patient and help them. And at any point, guys, if you need to sit down, you can. But could you give them a huge clap because they've come? When I got my briefing from Kylie and Dr. John, Kylie had to leave. Her pager went off and she went off to save someone who had a stroke. So Kylie, I know you could go at any time. Tell us about 2 or 3 of these people.
So down here we've got a bunch of survivors who have come in to help us volunteer to show what the diversity in stroke is. We've got Paul, for example. He was 47 when he had his stroke 10 years ago this week. He had 2 children at the time. Unfortunately, Paul's not returned back to work, but now he's got a granddad daycare happening, I believe. We've got Dr. Wang, who was a radiologist when he had his stroke. He had just cycled 1,200 kilometres through Paris the year before, and he has unfortunately not been able to return to work as well. But we've got Michael, who had a stroke. He was treated in under 30 minutes at RPA.
Round of applause. Speed is everything.
And he has done very well as a result of his stroke. And we do have a young lady by the name of Sheridan wanted to come in about her son Zenon, who had a stroke when he was 8 months old. And he has now turned 2, but unfortunately he was sick overnight, so he wasn't able to join us.
The key first message is it's all ages.
Anyone can be affected by stroke, okay. Yes.
Look, I'd love you to take your seats, but can you give them all a really warm round of applause? If you wish to stay there, you're welcome, but I know that some of you may not, and you can even sit on the end of the stage if you want to stay, but I just don't want to make you feel that you have to. John Worthington, I understand you always say, give them the stats. What are the stats? What have you achieved at RPA in terms of saving lives and reducing damage?
I think the real trick has been that we've taken new evidence, we've translated it, and we've reached out across the state and we've reached people who previously didn't have options to reduce their disability. And we've done it quickly, we've done it effectively, and we've matched or exceeded the international trial results in terms of the quality of the care and the patient outcomes.
And can I ask you, can you give me some numbers?
Well, if you reach a stroke unit, you've got a 30% chance of having less disability. You've got a lower mortality by 30%. But to take things further, you need stroke reperfusion. If you get an intravenous drug within 4.5 hours, 30% less disability. But that won't cover these people often with these large vessel strokes. The endovascular clot retrieval that ECR now provides is going to reduce disability by 30% in a population that, frankly, often does quite badly despite the other services. And we are now gone from something like 26 a year to something that's probably now approaching 300 cases a year. But we're reaching out across New South Wales, and every stroke service that we've worked with has improved its stroke care for all of its stroke patients, not just the ones that come to us.
Because, Kylie, you and Dr. John have been going around the state talking to people to help motivate all the other health staff to get people to you quickly. And we'll come to the AMBO in a minute and we'll talk helicopter.
We have, most certainly have, and as John said, a lot of the hospitals have actually increased the number of people who are being treated, and they're doing it a lot quicker than they used to. And people are getting to us from Dubbo, it's under 5 hours, they're generally to us being treated.
This matters to me because I go to Wellington 45 minutes from Dubbo regularly. John, you call this Australia's newest team event. A word on team before I go to them.
Yeah, the The really amazing thing about this is there's literally hundreds of people across New South Wales on rosters that meet and greet these patients and get them to us. And these are people that 3 or 4 years ago wouldn't have thought something needed to be done quickly, and now it works like clockwork. And to watch the teams at the bedsides, watch them in the angiogram suite, that's the marvel of this.
Yeah. Minutes matter. Time, critical focus on the patient's needs. Come forward, I want them to be able to stare at you. Minutes matter. How do you make a minute matter?
Every minute counts in stroke. It's 1.9 million neurons for every minute, so every part of our process has to be done as fast as we possibly can.
Could you say that again? How many neurons?
1.9 million every minute.
Spooky. Will we get the guys going? I think so. See, look at that. That took about 1 second. If I was in a stroke unit, I'd have to have a quicker way of doing it. Ladies and gentlemen, we're now going to move into what we call the rush. I'm going to introduce you to the entire process of saving me from a stroke. Okay, we'll come a little bit later. We should come to it now. Oh, well, we'll come to it in a second. You're wonky in any kind of a way, don't wait, ring 000. What happens when you have a fast positive patient? Jenny Dunlop, project manager, stroke, New South Wales ambulance. She doesn't just manage the state, you get in the ambulances and do stuff too, don't you?
I do.
You do. So if anything happens to me right now, I'm safe, you'll do something.
Absolutely.
Okay, so what is a fast positive patient?
Okay, that's an assessment tool that our paramedics use to look for facial droop, arm weakness, speech abnormalities. We're very focused on ascertaining the correct time of onset because that's important for the team in terms of treatment. If that's identified by our paramedics, our first priority is urgent transport to the highest level stroke service that we can get to, and we pre-notify the emergency department so we give them time to prepare for our arrival.
Now, John said earlier you get less damage and less death if you get to a stroke centre. Just explain that again. So if any of us are ever in this trouble, we're yelling at the ambulance, get us to a stroke centre.
They don't need to worry about that. All of our paramedics across the state know exactly where those centres are.
Okay. But you've got a better chance if you get there.
Yes, you do.
So fast, just unpack it again. It's
Face, arm, speech and time of onset.
So get one of them on your fridge. What happens to people's face?
They can get facial droop. We might, if it's subtle, we might ask the patient to smile and we look for any asymmetry there. We get them to hold their arms up for a count of 10 to see if there's any weakness or drift. And we listen to them obviously speak and just see if there's any difficulties there.
So what do? You go, oh my God, they're fast positive. You ring ambulance control. Do they ring you?
We radio through to ambulance control, and ambulance control uses what we call the bat phone to the emergency department.
Great, let's go to the bat phone. Oh, there we are. You've rung through stroke to resus 6, emergency. Oh, look, we've even got the number there. I'm now introducing Kelly Burrows, who's the clinical nurse consultant in the emergency department. Again, come forward so they can stare at you, because otherwise they can't see you through that thing. If you fall off, everyone will save you. Everyone's medically trained. What on earth is the bat phone, and how wonderful. This is the actual bat phone, and look, Batman is actually on top of it. So what is it?
It's a direct line from the ambulance to let us know that they're bringing in critical unwell patients.
So when that phone goes off, what happens?
Generally mass chaos, but it's winter at the moment. But generally just alerting us. We'll try and get a bed ready or a space ready for the patient that's coming in the case of a stroke. We would organise the equipment to take with us to the CT scanner with the patient and with ambulance.
And my understanding is that as part of this whole 24/7 comprehensive stroke service, you've all been getting quicker. So how have you got quicker in ED when the bat goes off?
We have a pretty good relationship with the stroke team. We have Kylie on speed dial, and we've incorporated a lot of their training into our training as well. So, creating pathways, mandatory training, that sort of thing.
That's interesting. So it's both training, but it's also human relationships.
Relationships. Everything's about relationships as well. We're all there for patient safety and great patient outcomes.
Look, thank you so much. So you can go away now. You can step back. We're now in the emergency department. A team is paged and they arrive. Here comes someone now. Are you Dr. John O'Baskin and a neurology trainee?
Yeah, that's right.
And when you grow up, you'll be Dr. John Worthington, who's a neurologist. So you're on the way to being him.
I'd have to get a couple of extra lenses on my eyes, but we'll see.
Kylie, can you come around on the other side of me, please? So I'm now with the team has been paged and they arrive. What do you and Kylie do? You've roared in.
Yeah, so basically our job is to assess the patient in a quick and calm fashion. We assume that they've had a stroke, and the question is really, can we offer treatment? And we can offer treatment if we think that the stroke is going to cause significant disability that outweighs any risks of treatment. But really the aim of the game is to get the patient into the scanner as quick as possible to assess their risks of treatment and any benefits from treating them.
Wow, this is all happening so fast. What do you do?
I generally boss everyone around. I tend to coordinate it and make sure everyone's involved who's there should be involved. Let the CT know so they can go through to CT. We get the story from the ambulance and then we talk to the families.
What's interesting is just meeting Kylie, I automatically got her to brief everybody else. There's just something natural about you that you're just team leader. You even said, Kylie's my team leader, and said, let's have her up on stage. What is it about you?
Just a personality trait, I guess.
Listen, can I come over to the patient? If you could move forward, and very big welcome to you. I'm just meeting you for the first time. I'd like to introduce Marina Chiavetti and her husband James and daughter Ziggy. So could you please make them welcome? You know, one of the things we're wanting to emphasise is ring that 000 and don't wait. Unfortunately, because of our time, we can't hear your whole story, but it actually took you quite a while to get yourself to ring 000, and you'll get them to do the opposite now. Even indeed, as I understand, as you were entering RPA, you still didn't have any acceptance that you were having a stroke. Just because everyone will want to know this, what sort of things were happening to you, your body and your thinking that made you think something was wonky? Because you managed to get to a GP, so you knew something was going on.
Yeah, so I didn't have the typical stroke symptoms where the facial, the fast certainly wasn't applying to me. I could speak perfectly coherently. I had an eye that was going wonky, and so I thought I just had some vision things that were going on and assumed it was a migraine. And it was only when I got out of a taxi and walked into a lamppost that I realized maybe I needed to get somewhere for some help.
And did you drop something at some point?
Yes, I dropped my breakfast all over a table. In the office, I thought I had a hangover. I did have a hangover, actually, and I thought I was having a migraine.
So something's happened at Brekkie, something's happened at the office, you get in out of the taxi, you walk into a lamppost, you didn't ring 000. What's your message to anybody who feels wonky, seriously?
Definitely get checked. So, and that's my message to everyone. So certainly, even when they were wheeling me in for the CT scan, I was like, I'm not having a stroke. What are you guys doing? You're overreacting. And so, thankfully, these guys didn't listen to me.
Can you wait there for 1 second? Could I have my ambulance person again? My late mum rang your people probably scores of times over a 25-year period. My observation was you're never cranky when we ring. Can you explain that? That if we ring 000, your peeps look after us, don't they?
That's what we do. It's why we've all joined the ambulance service, is to help people. So if people are in need, then of course we're happy to do that.
I just wanted to emphasise that because we mustn't hesitate, must we?
No, definitely not.
Because you'll make a quick assessment, and if you need to go, you'll go.
Absolutely.
Yeah. Thank you so much. I just wanted to make that point. Can I just ask you, as you came in and you're explaining to them that you didn't have a stroke, what do you remember as you arrived in RPA and this mob start coming around you? What are you seeing? What do you remember?
The picture, it was a few pictures back, literally of the, being wheeled in and all of the neurosurgeons lined up. I think there were about 10 of you waiting for me. And I thought, wow, this is exciting. But what an overreaction, because I'm just having a migraine. So it was, I certainly felt like I was in the right place and had all the right care that I needed. But I also thought probably more than I needed. Thankfully, you guys know what you're doing. And when my husband arrived, he was like, wow, that, what happened? How did this happen so quickly? But obviously.
I don't feel I have time for the family, but I'm going to overcome that, just as I hope you always will. Tell us, mate, what did you think as you got in there and saw whatever? What did you see when you arrived?
Pretty much the scene that you can see on the photos there. There was just Marina lying on the bed, smiling away, going, I've just got a migraine. And everyone else is going, oh, no. So calm, so helpful, so polite. so polite. And, it's just, it was like this weird sort of paradox of, it looks really, really serious, but everyone was so calm and chilled out and happy. It's like, yeah, we just got to do this, and we think she's having a stroke, and it's in a really serious place, and we can do these kind of different options. Shall we do them?
Wow. Wow, give him a clap. Thank you. Okay, she's had the scan. Something is happening inside her head. Group assessment and treatment. Come forward, Professor John and Dr. Grace Orr, Interventional Neuroradiology Fellow. Now, I just want to quickly explain. My understanding is, at that moment, you've sort of got two, you've probably got more options, but I want to just hear in a nutshell, what is IV thrombolysis and what is clot retrieval? And what, can I just ask John first and then I'll come to you. So how would you answer that question?
The intravenous clot retrievals is administration of a drug. You've got to select the patients very carefully. You need to be under 4.5 hours, and minutes matter. So if you're at 80 minutes, that's better than 90 minutes. If you're at 30 minutes, it's wonderful. So this drug is given, can be given straight after the first scan. So before we move on to the more advanced scanning, we start mixing the drug up if we think they're eligible, and we will start getting the lines ready to administer it. It will give you a 30% reduction in your disability, which is the main concern of patients, but it does have dangers in the first 48 hours. It can cause brain hemorrhage. We must be careful with it. We still face the brain hemorrhages, which can be fatal, and we have to trade that off against the other benefits, which we explain to the patients and family.
Thank you. And what is this amazing clot retrieval? Because you do it, don't you?
Yes, I do. So clot retrieval is just a procedure that's done in the angiography suite, and at RPA we actually have a quite recently built, purpose-built suite for neurointervention, which has been fantastic. So the patient is put to sleep generally with the anaesthetist, and then we introduce a series of catheters up through the groin, so it's like a keyhole procedure. And now more recently we can also do it through the wrist as well. And then we just introduce a series of catheters to try and extract the clot that's blocking this big vessel in the patient's brain and try to restore blood flow to that part of the brain.
I noticed there, look, there's a clot. Can we see the clot? Just because it's, if we could click on through, there it is. And how do you find it?
We find it just by doing an angiogram, so we inject the contrast through the arteries and then we can see where the clot is.
So there's, in a sense, there's multiple scans. What's the benefit of the clot retrieval? Why is that so special? Not the clot itself. You know, as I understand it, this clot retrieval process is central to what you're now offering in your 24/7 service. What makes that so special?
These are large vessel strokes. These are strokes, quite frankly, that are much more likely to end up in a nursing home rather than returning to work. And previously, we couldn't always dissolve them. Now, we can go ahead, remove that clot, and 30% of those patients with our worst and biggest strokes are going to be less disabled. And that's something we just couldn't do 3 years ago.
Can I ask Simone to bring my friend Joe, the pasta man from Haberfield, up? And just while Joe comes up, and he's my last person in this story because sadly our time is up. Evidently 2 people in Australia have had a stroke while we've been on stage. Where do the helicopters come in?
Transport. New South Wales has a tyranny of distance. Long drive times. We need the helicopters, we need the fixed wing planes to get those patients to us quickly. We need those planes and helicopters to get to the distant parts of New South Wales and return the patient to us. Without that, many of the people in New South Wales would not be able to access this.
So Kylie, you're presumably running up to a helicopter pad all the time, eh?
I do. I spend a lot of time on level 11.
Seriously, you do?
Yep. Yeah, we go and meet the helicopter so we can bring the patient straight down to the angio suite.
Do you ever go home?
I go home occasionally.
Because everyone says they've got your number on speed dial. Look, I'll just come over. Now, Joe and I met at the Patient and Family Symposium on Monday that was part of Innovation Week. And first of all, let's promote your pasta shop in Haberfield.
Okay, I operate a small pasta factory on Ramsay Street. It's called Pep's Pasta, and I make all sorts of fresh pasta.
You were treated at RPA and then you spent quite a long time at Balmain, and I wanted to conclude, one, by celebrating your recovery and the recovery of all the other patients from stroke who've come today, and to thank you again for coming. Just give us in a nutshell, how long were you at Balmain and how have you reached the point where you can walk up on stage?
Well, at first I spent a few weeks in ICU at RPA, and I wasn't able to walk, and they took me over to Balmain, and the guys there at rehab spent quite a few weeks, I think it was about 2.5 months, in rehab at Balmain.
And we talked about the flexibility that your wife was able to take you in and out of the hospital, that she could come at any hours because of work, and that she really was a partner in your care with the team.
That's correct. The hospital offered a gate pass. So there were occasions that I didn't want to miss, like Mother's Day. My boys, I got a pair of twins, and their birthday was around my stroke, so really wasn't a good time to have a stroke.
How long since you had your stroke?
1.5 years nearly.
And are you still doing rehab?
I am indeed. So I've got stroke outreach that helps me out, and a private physiotherapist.
I'm just so grateful. Joe has made the effort to come here today just to be the last voice in this session. So would you please thank him and the team and our other patients. Thanks,
Thank you.
Was that good or what? Give them another clap.